Good evening, everyone, and welcome to MitoAction's evening roundtable discussion with Dr. Georgianne Arnold. Tonight, Dr. Arnold will discuss two current exciting MCADD trials that have recently started. One explores the use of Dojolvi, and the second, the use of phenylbutyrate with MCADD patients. My name is Stephanie Harry. I'm an LCHAD parent and one of the patient support coordinators at MitoAction, and I'll be your host for this evening. Today's discussion will be recorded and available on MitoAction's website in the coming days, as well as on our podcast, Apple Podcasts, Google Play, and Spotify. This space is a little different than our traditional expert series. We set this call up as a Zoom meeting, which means that you have both video and audio access. Please take this time to make sure that you're muted and that your video is either on or off, depending on your preference. It's very important that you keep your audio off while you're not speaking. This will give everyone a more pleasurable experience. If you have any questions during Dr. Arnold's presentation, feel free to put them in the chat and I can ask them after the presentation. Or if you'd like to ask your own question, we encourage that. Simply raise your virtual hand after the presentation and I can call on you. So without further ado, let me officially introduce Dr. Georgianne Arnold. Dr. Arnold graduated from Indiana University with degrees in biology and chemistry. She has a master's degree in medical genetics from Indiana University, Purdue University at Indianapolis, and graduated from medical school at Upstate Medical Center in New York. She completed a residency in pediatrics at Northwestern University and a fellowship on genetics at the University of Colorado. Dr. Arnold is a board certified in pediatrics, clinical genetics, and clinical biochemical genetics. Previously, Dr. Arnold was faculty at the University of Arkansas and the University of Rochester. She's now professor of pediatrics and clinical research director at the University of Pittsburgh Medical Center. Her main interest is clinical research in inborn errors of metabolism. She is currently conducting numerous clinical trials for a variety of metabolic disorders and is the longitudinal project principal investigator for the National Rare Disease Consortium for PKU. Dr. Arnold has authored more than 70 medical publications and received the Shapiro Award for the best publication by a Society for Inherited Metabolic Disorders members in the journal Molecular Genetics and Metabolism for her paper, Adelphi Clinical Practice Protocol for the Management of Very Long ACL-CoA Dehydrogenase Deficiency. She has presented papers at numerous national and international meetings and is currently the president of the Society for Inherited Metabolic Disorders. And Dr. Arnold, is always a pleasure to have you, whether it's at MitoAction's conference, here. You're amazing. We really appreciate all the time and energy that you give to our community and just the time you take to explain things. Everyone here is in for a real treat tonight. Dr. Arnold is amazing at explaining things, and so I'm super excited, and I'll go ahead and turn it over to you.
Well, thank you very much. I'm also happy to see our study coordinators are on the line, so they'll be able to answer questions, and I'm going to share my screen. Okay, there we go. Get things centered, and we'll go to slide view. Now, let's make... Okay, can everyone see? I hope so. All right. So I want to talk about two new therapies for MCADD. One is triheptanoin, or also called C7 or Dojolvi. The other is phenylbutyrate therapy. And so the other person working on this with me is Jerry Bedoyan. And we work at Pitt with Dr. Jerry Vockley. There we go. So I have research funding from the NIH and from the Mellon Foundation. And these studies that we're going to talk about today are funded by Ultragenyx, who make the triheptanoin or the Dojolvi, and Acer Therapeutics, who are providing the phenylbutyrate. So what is fat? Fat's the most efficient energy source in your body. it's made up of chains of carbons and hydrogens. And so fat is really hydrocarbon. It's like gasoline or oil, only it's got its own chemical structure. So short chain fats have 4 to 6 carbons in them. Medium chain fats have 6 to 10 carbons, and long chain fats have 12 to 18 carbons. So fat is oxidized or burned to make energy in your liver. And each cycle of fat oxidation takes off 2 carbons. And those 2 carbons are then burned for energy in the liver, or they're turned into a ketone, and they're exported out into another tissue to be burned for energy. So we're going to talk today about people with a problem with metabolism of medium chain fats. Why do we need treatment for MCADD? I mean, and actually, interestingly, when I posted this study for the first time, people actually asked me that. Well, you just don't let the patients fast and they're fine, right? But in fact, we still lose people. I'm aware of one adult recently, and a couple of children that have not been published. This is one case that they have been published. But it's not perfect. So what does MCADD mean? Well, medium chain, 6 to 10 carbons, acyl-CoA, the chemical name of the working end of the fat, dehydrogenase and deficiency. And for those of you who have been immersed in this for years, I apologize if I'm talking down to you. So what is a fatty acid? So fatty acid is chains of carbons and hydrogens. And then this R just means there's more of them out there. So if it's a medium chain fat, there'd be a total of 6, 8, or 10 carbons. So in order to get metabolized, this fat attaches a CoA group. CoA is an energy molecule that's made from, if you look at your vitamin bottle, pantothenic acid. So the first step in fat metabolism is a dehydrogenase. And the nice thing about biochemistry is that the names of things usually kind of tell you what they do. So a dehydrogenase is going to take away hydrogen. So you're going to take away a hydrogen here. It's going to make a double bond. That hydrogen is going to go onto there. And that is going to go off into something called the electron transport chain, or the respiratory chain, where it's going to be turned into energy. The first carbon 1 has no number. I don't actually know why it happened that way. The second carbon is alpha. The third carbon is beta. The name of fat oxidation is beta oxidation, because what's going to happen is it's a 4-step process by which you're going to oxidize the beta carbon. Because, like I said, in metabolism, the name usually tells you what it's doing. So this is a shortcut way we often look at fat. So each of these points is a carbon atom. The hydrogen atoms are not shown. They're just assumed. So here we have the C double bond O CoA. Then there's a 4-step process by which you're going to snip it here. You're going to create the double bond here. You're going to snip it off, and you're going to have this acetyl-CoA, which can be turned into a ketone and burned out for energy, and a new fat that's 2 carbons shorter. And you just keep lopping off 2 carbons at a time until there's nothing left. So this is the long picture. So this first step is the acyl-CoA. This is the acyl-CoA. Dehydrogenase, taking away the hydrogens, making the double bond. And so this has chain length specificity. There's very long chain, or VLCAD, medium chain, MCADD, and short chain, which is SCAD. And then the next step is the adding water, a hydratase. So you're going to add water over that double bond and make this hydroxy group. The next step is another acyl-CoA dehydrogenase, only now it's going to work at this 3-hydroxy. So we often call this enzyme the CAD enzymes, VLCAD, MCAD, SCAD. Here, it's CHAD because it's hydroxy, so L-CHAD. is the most common deficiency in here. And then you're going to split it off. This acetyl-CoA can go off and become a ketone body. And now you have a fat that's 2 carbons shorter, and you're going to do it again and again and again till it's gone. So if you have a long chain fat disorder, and fat is the most efficient way to provide energy to the body, it makes sense that you could treat your patients by feeding them medium chain fat. That should work very well for them. So someone named Charlie Rowe, Dr. Rowe, got an idea that what would happen if we gave patients with long chain fat metabolic disorders an odd chain fat. So instead of the medium chain fat, which is supplements, which are usually a mixture of C6, C8, and C10 carbons, what if we gave them 7? So it turns out that if you start with 7 carbons and then you slice 2 off, you have 5, and then you slice 2 off, now you have 3. This 3 carbon piece gets metabolized a little bit differently, and it feeds into metabolism a little bit later in the metabolic cycle. So it replenishes some things that could be missing. So C7 can kind of give you a double boost. It can provide energy from fat metabolism, going from 7 to 5, and then from 5 to 3. And then it can replenish, that 3 carbon piece can replenish other things later down the energy cycle. And in theory, by replenishing things later down the cycle, it might make it easier for your body to make glucose. But you would think that we would not want to feed a medium chain fat to people who can't metabolize medium chain fat. So MCT supplements would be contraindicated in fatty acid oxidation in people with MCADD, or with medium chain fat oxidation disorders. But you know, a lot of the best scientific discoveries are serendipity. There's a little serendipity here. So Dr. Jerry Buckley, who is the American guru of fatty acid oxidation, was, when Dr. Rowe retired, and we did lose him not that long ago, but when he retired, he took his work and handed it off to Dr. Buckley and said, you know, finish my work for me. And so they were testing C7 for long chain fat metabolism disorders. And they were using a cell line that was MCADD deficient as a control. So if the experiment worked in the long chain fat cells and didn't work in the medium chain fat cells, it would tell you, you know, that the experiment probably was correct. So the MCADD should have been your negative controls. But when they tested C7 in MCADD, they found that there was some activity. So then they tried feeding this MCADD deficient cell line C8 to see if there was something wrong with the cell line, and it was appropriately 0. So for some inexplicable reason, it looked like this MCADD deficient cell line could metabolize C7. So he guessed that it must be the SCAD enzyme. So SCAD normally will do 4, 5, 6 carbons, and maybe it could get up to 7. So they pulled some purified SCAD enzyme out of the freezer and fed it C7, and it metabolized it. So this is just the research result. So they took control fibroblasts who could metabolize fat just fine. They fed those fibroblasts short chain fat, C4, did fine. Fed it long chain fat, C16, did fine. Fed it medium chain fat, did fine. Fed it C7, did fine. The controls metabolized everything just like they should. Then they took fibroblast cells, and some of you, if you've ever participated in a research project and gave a skin biopsy, maybe it was some of your cells, and they could metabolize C4 just fine, and they could metabolize C16 pretty well, but you got to realize you get stuck kind of halfway down when you go from the long chain, you make it shorter and get down to the medium chain. It couldn't metabolize C8 at all, which you wouldn't expect it to if it was MCADD, but it could metabolize C7. So then this is when they got the pure short chain SCAD enzyme out of the freezer. And sure enough, it couldn't do anything on the long chain fat. It did absolutely fine with the short chain fat, like it should. Didn't do much at all with the C8, but it could metabolize C7. So then that raised the question, could we give people with MCADD extra calories and energy from fat metabolism if we fed them C7? So they started with mice. It turns out that when you're initially fasting, your body, when you first eat, your body takes the sugar and turns it into something called glycogen and stores it in your liver. After that, once your liver's full, it takes that extra sugar and makes fat out of it, unfortunately for us. When your body then is getting, so the first several hours after you eat, your body gets its energy from pulling that glycogen, pulling the sugar out of your liver. But when that's all gone, then it has to start metabolizing fat. So your body frees up free fats and sends them to the liver and says, metabolize me. So if they took the mice and the MCAD deficient mice and then cold challenged them, that's how they need that energy to shiver. And that's a way you can bring out their metabolic disorder. And you can see that there was a lot of fat in that liver when they were getting no C7. And the more C7 they gave them, the less fat was in their liver, which was showing that they were in fact metabolizing that fat for energy. And it was looking an awful lot more like the control. So this, I think the bottom one's easier to see. This was liver glycogen, because if you can make and use more glycogen, you can fast for a longer amount of time. So you can see that the more C7 that they were, the more C7 they were fed, the more purple glycogen they were able to make in their liver. So it appeared that feeding these mice C7 was good for them. So we're ready to try this in people now. So we're calling it phase 2 because the drug Dojolvi is actually already approved for patients with long chain fat disorders. And a lot of the initial safety studies on what happens to people who don't have metabolic disease when you give them the drug have already been done. So we're starting this at what we call phase 2. And we want to study 8 patients with MCADD and starting at age 16. We don't generally start research studies on babies if we don't have to. So we want to look at baseline, at their glucose. Now, those partially broken down fats, when you get stuck in your fat metabolism, will bind to carnitine or glycine. So we will call them acylcarnitines, acylglycines. So you can study those and see what builds up, and it will tell you where in your fat metabolism you're blocked. Free fatty acids will tell you how stressed you are, how much your body's trying to release fat and sending it to the liver and saying, please metabolize me. Beta hydroxybutyrate is a ketone. So it's saying, how much ketones can you make? So we wanted to basically take patients with MCADD and fast them before and after giving them C7 to see if it improves their ability to fast. And some of these fasting studies have already been done in Europe, but not with C7. They've just been done to see how long can you make people with MCADD fast. So we do feel that those studies have been done. So how will we make this fast safe for people with MCADD? So at the beginning, patients are going to get an IV for access to give glucose if we need to, for blood drawing. Their fast will begin after supper because most people don't eat in the middle of the night. So you really, fasting starts when you don't have your breakfast the next day. We will check finger stick glucose anytime the patient reports feeling symptomatic. We'll be checking finger stick glucose every 3 hours into the feed, we'll start checking blood glucose at every hour at 21, or sooner if the finger stick glucoses are dropping down. And the fast will be stopped if the patient's symptomatic or has a blood glucose of less than 60. And during the fast, people can have calorie-free and sugar-free beverages. So you can drink, but you can't eat. So after that initial fast, when we measure all the metabolites and see how long that person can fast and how stressed their body seems by the fast, they will start getting a triheptanoin or Dojolvi, first at a low dose and then a higher dose and then a bigger dose. Because if you start it too fast, it can upset your stomach. So it's going to come in over a week. And this is an open label study, which means everybody gets drug. There'll be no placebo group. And if somebody has to go up slower on their dose because it upsets their stomach, they will. So for 100 and let's say for a 70 kilo person, 150 pound person, a half a gram per kilo is going to be about a little over an ounce, about 35 cc's a day, and it'll get split up into 3 or 4 doses a day. And then we're going to fast them again. And then they're going to go on a higher dose. So a gram per kilo, up to a gram per kilo, and then repeat the 24-hour fast. And then the drug stops at that point. So if you want to look at the design, you get admitted to the hospital, you do your overnight fast, we measure all your metabolites, you continue the fast until either you get symptomatic or you get hypoglycemic or 24 hours. Then you start the triheptanoin, you go home for a month on increasing doses of triheptanoin. Then there's a second study visit where the same thing happens. Then you go home on the higher dose, and then a final study visit where everything kind of stops after that. So the patients will be 16 or older. The study endpoints are the prevention of hypoglycemia or the increase in time until you become hypoglycemic with your fast. And probably, since most, the European studies have shown that the average person with MCADD can fast for 24 hours, but I don't think everybody can. But I think the money's really going to be in the reduction of the fatty acid oxidation intermediate. So showing that their body's not stressed by the fast for a longer period of time. So, so even if the patients don't get hypoglycemia, do they have less buildup of toxic intermediates showing how stressed their body was? So if this first study looks promising, then we would move on to a phase 3 trial that would be placebo controlled. Because if you know much, our bodies are wonderful things. But often when we think we're getting treated for something, there can be some improvement, even if what you were on was basically a sugar pill. And it's a little unclear in some cases why, whether it's psychological, in some cases it can be physiological. Just believing you're better can make you feel better. So, so to do a real study to get this FDA approved for this indication, they would want us to do a placebo-controlled trial. But the details of that, that's not planned yet. We need to get our initial data showing that it's safe and that it's having some benefit before we jump the gun and talk about a phase 3. So the second study is phenylbutyrate. And this treatment works on a totally different principle. So proteins are like beads on a string, like pearls. Think about it as like a strand of pearls. And those pearls, after the string is built, they twist on themselves to form a final structure. And that folding is facilitated by proteins they call chaperonins. So they chaperone this and help it twist up into the right shape. And sometimes you can actually give a small molecule that will help it to fold right. So you have your primary amino acid structure that folds and then folds some more until it folds into this final structure. And so let's say this is the part of the molecule that recognizes, this is MCADD, the enzyme, and this is the place that recognizes the medium chain fat. So if this was folded wrong, and this was like inside the molecule, it wouldn't have the opportunity to bind the medium chain fat, or maybe if it's just off a little, it wouldn't hold it right. So you need that molecule to fold properly. And then when a molecule is misfolded, your body recognizes it as wrong and destroys it. So even if you had something that was a little bit off, if you could at least stop your body from destroying it, you might get a little bit of help from that enzyme. So it's a lock and key model for anybody who took biology. So this is your MCADD enzyme, and this is your medium chain fat, and they recognize each other and bond together. So you need to have this active site in just the right shape. So sometimes if there's something wrong in that shape, if you can stop that enzyme from being degraded, if you think about it like when you've copied a key 3 or 4 times, it's now a little off, but if you jiggle it enough, you might get it to open the door. So if you can keep this enzyme folded into the right shape, a close shape, you can at least maybe get enough bonding here to have some fat that's metabolized. So the most common MCADD mutation in people from Northern European ancestry, which is most of the US patients, is what we call this. This is shorthand. C means it's the DNA structure. 985 is the base pair in the string of DNA number 985. A to G means an adenosine has been replaced by a guanine. So it's one base pair change. So amino acids, if you remember your old biology, every 3 base pairs code for an amino acid. So the amino acids number is usually about 1/3 of the base pair number. So at amino acid 329, it should be a lysine, but because the base changed, it's now a glutamate. And so that causes a change in the folding of the protein. So P stands for protein, K is shorthand for lysine, E is shorthand for glutamate. So that's what you would say, P K329E. So that's the K329E mutation. Now, older literature that was using a little different sequencing techniques were calling that amino acid 304. So if you decide to go out and read about this on your own, you might see it as K304E or as K329E. So most MCADD patients of Northern European ancestry have at least one copy of this, and it is a folding defect. So if you could help that enzyme to fold better, your body wouldn't degrade it, and it might still work a little. The enzyme might still work a little bit. So there's a drug called phenylbutyrate, and we use phenylbutyrate in different metabolic disorders called urea cycle disorders. So phenylbutyrate gets metabolized in your body to something called phenylacetyl-CoA. It takes the amino acid glutamine that has 2 nitrogens on it, and it makes this thing called phenylacetylglutamine, and there's the 2 nitrogens, and that's urine soluble. So you can basically pee out nitrogen, and your body will take other nitrogen molecules, make more glutamine, and then you'll pee the glutamine out. So it's a way to get rid of nitrogen if your body's ability, your regular enzyme activity can't do it. It turns out that when your body metabolizes phenylbutyrate into the active compound phenylacetyl-CoA, it actually does one step of beta oxidation using MCADD. So they thought, well, maybe if the enzyme, maybe if the phenylbutyrate can bind into the MCAD enzyme, it could hold it open a little bit, and then MCAD could get in there and do some work. So basically, this is what happens: is the phenylbutyrate becomes the CoA. We talked about CoA earlier. Your first step is the MCAD enzyme dehydrogenase. Remember, it made the double bond here. It took away the hydrogens. And then the hydratase added the water, put on the hydroxyl group, and then it split it. I'm sorry, then there was the next dehydrogenase, which made that a double bond, and then it splits it off there. So you need MCAD to metabolize phenylbutyrate, but they thought maybe phenylbutyrate would help stabilize the enzyme. So they actually did some lymphoblast studies. We remember we talked about fibroblasts, which were skin cells. Lymphoblasts are made from blood cells. And if they looked at the activity of their MCAD enzyme, they found that it's sort of general. As you gave more phenylbutyrate, the MCAD enzyme seemed to work a little bit better. So then they used lymphoblasts from people who had MCAD deficiency. And they did find that the more phenylbutyrate they gave people, the better their MCAD enzyme worked. So they tried it on 4 people. So this is a step ahead of the Dojolvi study, because they've already given this to 4 people. 2 of them had both copies of 985. The other people had 1 copy, and then on their other gene, they had a second mutation. And 3 of the patients, 1, 3, and 4, actually did have some symptoms. 1 felt some fatigue with exercise. 1 had nausea and vomiting with illnesses. 1 had a history of hypoglycemia as a child, and now had some issues with intercurrent illnesses. So when they looked at the urine acylglycines, remember I said glycine would hook onto partially metabolized fats. And if you studied that, it could tell you what was bound to it. And there's a couple of things. Hexanoyl glycine is one that builds up in people with MCAD, and phenylpropionyl glycine is another one. So these were the molecules that looked the best on subjects 1, 3, and 4, who were the symptomatic subjects. And so you can see that the more phenylbutyrate they gave them, the less abnormal metabolites they were making. And so for this patient, it didn't take much phenylbutyrate and to really drop it. This patient really didn't have a huge response, a little bit. And this patient had a very nice response, but at a higher dose. So we need to do a little dose finding, but it appeared safe for these patients. So this study, the patients will have to have at least 1 copy of this mutation. There's going to be 2 cohorts for this study. One's going to be 16 and up, and now they're going to allow us, the FDA is going to allow us to do some younger patients. Still no babies yet, but we're getting there. So this one only has 2 fasts. So there's your initial study visit where you'll fast, and the same principles as the last time. The patients will go home for 5 weeks, and then they'll come back and have a second visit and a second fast on their phenylbutyrate. And then at the end, the drug will stop until obviously we have proof that this is working and that it's approved. So they'll be looking at hypoglycemia, or the increase in time, the reduction of the intermediates. And this one actually has a quality of life. Do patients feel better? So this was going to do 2 cohorts with up to 12 per cohort. And the subjects will be randomized to 3 dose regimens, once a day, twice a day, and then a higher dose, and then the same with the younger age. So to be in the study, obviously you have to have MCAD. You have to be able to comply with an overnight admission. This study will pay transportation for an adult to come. It will pay for transportation for a child and a parent to come. And obviously, a negative pregnancy test for females who are theoretically reproductive has to obviously be assigned consent. Minors have to assent as well. And you have to agree to use contraception or be abstinent during the study, because we want to make sure that this doesn't have any effects in fetal development. So for the triheptanoin right now, we're only doing greater than 16. For phenylbutyrate, there's one copy, there's one cohort that'll be younger, and you have to have at least one copy of this variant. Who could not be in it? If you used an investigational drug within 30 days, if you're sick when you come in, or there's something wrong with you, if your liver looks like it might be sick. If you have a medical condition like renal insufficiency, for example, the phenylbutyrate's metabolized in your kidney. If your kidneys are not working properly, it would not be good for you to take this drug. So renal insufficiency will be excluded, and breastfeeding or lactating females will be excluded. Now, those are the two studies I'm talking to you about tonight. We may have some other studies coming up. They've requested us to actually just put continuous glucose monitoring on people with MCADD and see what happens to them just on their normal everyday life. What happens when they fast overnight? What do they look like during the day? That is in progress. The planning for that is in progress. We're hoping people won't need to travel to Pittsburgh, but that could be done through their local medical centers. But the details of that are TBA, so stay tuned. And the patients can do more than one study. You'll need to wash out the drug. So you need at least 30 days to get one drug out of your system before you go into the study to go on the next drug. But if you're somebody who has the kind of a job that you could come to Pittsburgh for a day a month, for 3, 4, 5 months in a row, you could do both studies. So actually, Elizabeth McCracken is a genetic counselor who's a study coordinator, and Jess Lindenberger is a nurse practitioner who will be helping to run the study. And I believe they're both on this call. And the studies are both listed on clinicaltrials.gov. So if you lose this slide, you can go on clinicaltrials.gov and find us. And this is the Children's Hospital at Pittsburgh. So this is the research building and office buildings and Ronald McDonald, more office buildings. And these clinical research inpatient rooms are right around over in here on the 9th floor. So that might be where you come if you want to be in our study. So let me stop sharing. I'm ready for questions.
So if you are joining us, you can feel free to raise your virtual hand. You can also feel free to share your screen if you'd like, so we can see everybody. I'm going to put it in gallery mode. And Dr. Arnold, I do have a couple questions that came through, and one of them is how is the phenylbutyrate and C7 administered?
It is a liquid. It looks kind of like vegetable oil, and you can mix it in food. You can drink it straight. Most people take it. The long chain fat metabolism patients will take it with meals, or we tell them to take it before physical activity. So if they're going to soccer practice, we tell them to take it before then. So the dose, if you were taking 1 gram per kilo and you weighed 70 kilos, which is about 150 pounds, and you took it 4 times a day, it'd be 70 divided by 4. That's what, about 2/3 of an ounce. 4 times a day.
So is that just the C7? Is the phenylbutyrate the same? Is that also an oil form or?
No, the phenylbutyrate actually comes as pills.
Oh, okay. And is that taken throughout the day or is that
Actually,
something?
Liz and Jess, are we using powder or are we using the packed capsules for phenylbutyrate? I don't actually know the answer to that. Because phenylbutyrate comes as a powder also.
I believe we're using the powder.
Okay, thank you. Since
And
that's
do you
what we're doing,
sprinkle that on your food or how does that work?
you can. Traditionally, the old phenylbutyrate tasted just god awful. But we used to patients used to mix it into baby formula, or you could take it on food. This particular product now is taste masked, so you can mix it with food or and eat it. Liz, Jess, anything you want to add?
How many participants are you looking for each study?
We're looking for let me go back to that slide. I think it was 8 for the Dojolvi study, and was it 12 for the phenylbutyrate? Is that what I said? It was on my slide.
It's 24 for the phenylbutyrate. There are 4 in
Okay.
each cohort.
Okay, 4 in each
And then
cohort,
8.
and then 2 cohorts, so 24.
Right.
Yeah.
Okay. Another patient just wrote in, what is the best case scenario in terms of time frame for when a baby will be able to take this medicine if all goes well with the clinical trials? I know you can't give like an exact thing, but sometimes it's just helpful to know, like, as a parent, it can feel so vague, like how long do things like this take? And with the C7, maybe, or both of them, maybe a little bit easier in the sense that there are already drugs being used in other communities. Like, I don't know if that affects like how fast things can move sometimes too.
If it took us a year to get FDA approval after the study finished, then they'd probably make us do another study with babies. So we're talking FDA approval probably a few years down and another research study down the line.
Okay. That's helpful. Would these 2 meds ever be used together potentially if they both get FDA approved?
Possibly, if you need both of them. That would be the trial.
Okay. But for trial's sake, like typically you have to do one and then the other, or for those 2, you couldn't be on both trials. You'd have to choose one if you were.
Yeah, you can do both, but not at the same time. You have to give at least a month to wash any drug out of your system before you move to the other one. So it has to be a clean trial showing that it was really just that worked.
Another patient asked why does this study require such a long NG? Fasting can trigger FAODs, as we were told.
Why do you want to fast for 24 hours? Is that
I think so. I think that's what she's saying. She said NG, but I think like, why is the fasting time so long? Like, why does it have to be 24 hours? But it does sound like if there starts to be symptoms before then that you'll stop and kind of notate that and then they can eat.
Yeah, if you look at the European fasting studies, most of the adult patients fasted fine for 24 hours. And most of the pediatric patients actually fasted fine for 18. And I know we're giving parents of babies, recommendations to feed their babies every 4 hours. But when you get a little bit older, you have a little more glycogen in your liver, and you do better. But I do think there are MCADD patients out there who will not tolerate a 24-hour fast and who will become symptomatic, and the fast will be stopped before then, especially if we know that in advance that there's somebody who doesn't tolerate long fasting. We would, there are things we could do, like start the fast. If we know they're not going to make 24 hours, we could start it later, or give them, a snack later, and so that they're not having to go till morning, or, so when you start a fast at night, if most people don't eat during the night, then they really aren't fasting until breakfast. So, so that it's not in the middle of the night when they're getting symptomatic. Although obviously when you're an inpatient in a hospital, there's somebody there with you all the time, but yeah, so 24 hours can seem long. And we would really want to know if in advance, if there are people who are not likely to tolerate that. And we might have to modify the protocol. So we won't force anybody to stay fasting for 24 hours if they're clearly showing us it's not good for them.
That's helpful. That's helpful to know. You mentioned 3 patients that have done the phenylbutyrate study already, and showed how some of those numbers kind of came down. But how did their symptoms change? Was there any information related to, because it looked like some of them were having issues, you said, like with inability to exercise, and I forget what some of the other symptoms were, but that they were having, but they were symptomatic. Did any of those symptoms subside as well, or?
That was just a short-term, one-time study.
Okay.
So they didn't stay on the drug
Long enough to need to know. Okay.
That was really kind of a safety study. Will we hurt anybody if we give them to this? And is there any evidence it might work? And it didn't hurt anybody, and there was some evidence it might work. So that's telling us we should go ahead with another trial, a longer trial.
If will people and or children be excluded from the study if they take other drugs such as levocarnitine, or if they're on a cyclic vomiting drug, or will they have to get off of the carnitine or cyclic vomiting medication in order to try the trial?
The drugs that we would not want you to be on would be valproate or Depakote. Those are drugs that would be involved in your body's nitrogen metabolism if you were in the phenylbutyrate study. Other than that, if they're not drugs that interfere, it's like, we like people to stay on their dose of routine drugs. So, if you're on carnitine, we would want you to stay on your carnitine. So there's just a couple of drugs that could interfere with the phenylbutyrate that we would not necessarily want people to be on. Depakote and valproate are specific drugs used for seizures, and it would be unusual for somebody with a fatty acid oxidation disorder to be on one of those drugs.
That makes sense. What if you recently were diagnosed with MCADD? Like if you have just gotten your genetic testing back and you finally get your diagnosis, but you haven't been put on any treatment for your MCADD yet, would you be able to participate in this study, or no, because you haven't found like a baseline treatment yet?
Most of the people that we see, their baseline treatment will be, we don't let you fast when you have intercurrent illnesses. So, generally recent diagnosis should be okay.
Okay.
We're hoping most people get picked up now by newborn screening, but we recently found it in the parent of a patient. So, and they had just never gotten sick enough to trigger symptoms, but they had it.
What is the lowest age you predict someone can take the medications if the drug is approved after these clinical trials?
If it's approved, it will be approved for the age groups we're testing. So, but we give Dojolvi to very young patients. So in theory, once it's tested and approved by the FDA, I would think any age should be eligible to take it.
Okay.
We give these drugs to babies. So yeah.
That's helpful to know. I just want to scroll through. I'm gonna scroll through and see if anybody else has any more questions. I'm gonna go ahead and I'm gonna just stop the recording and then just give a chance for
Get Jess and Liz to introduce themselves.
Oh, absolutely. Absolutely. That would be wonderful. And then I want to stop the recording and just see if people have questions that they don't want to be recorded, which sometimes happens too. So, but I would love for you guys to go ahead and unmute yourselves. You can share your pictures and introduce yourselves and what you do and how you participate with the study. All those wonderful things.
I think Mortimer was going to do this, so.
I was about to say, I'm running around tonight, so I'm just on my phone, so I cannot share my picture, but I am Liz McCracken. I'm a genetic counselor, like Dr. Arnold said, and I work as a clinical trial coordinator. I've been at Children's since 2006, in the clinic at first, and then about the past 10 to 12 years, I've been doing clinical trials.
Thanks so much. Is there anything you'd like to tell patients that are interested in the study?
I mean, we'd love to have you. And if you have questions that you don't want to ask or talk about, online in front of everybody, please feel free to email me and I can find a time to speak with you.
Wonderful. Jessica, would you like to introduce yourself?
Yeah, I'm Jessica Lindenberger. I am the research nurse practitioner in genetics at Children's. I was a research coordinator for almost 9 years and then went back to get my nurse practitioner degree. And so now I'm in that role. But I previously worked on the MCADD study we did with phenylbutyrate previously. So I'm excited to get some more patients on it and see what we can learn.
Wonderful. There is one more question that I thought of, Dr. Arnold, that I knew we were talking about before, that I wanted to make sure that we captured it here too, is patients that are in Canada. Does that affect their ability to participate in either of these studies?
I don't think so.
Okay.
Just Liz, do you know any different than that? But I don't think so.
Yeah, our international office right now at the hospital, we don't have a contract to be able to take patients for clinical trials outside of the United States. There's some legal stuff that has to happen that we don't have approval for.
Okay, I'm sorry, I didn't know that. I'm glad you were there.
But when that changes, or if that changes, Liz, can you let me know? Because I know that there's some patients in other countries that, like Canada, that would love to be able to participate if they were able to.
Of course, and this is for overall all clinical trials. This isn't just this specific one. It's to bring any patient in, international patients. So this is unfortunately a process going on at our hospital for a few years now, but if anything changes,
Okay.
certainly.
How does the insurance company, like how, one patient was asking, so in regards to clinical trials, does it affect your insurance company? And then if you go through and there's a good experience with the clinical trial, I think they just want clarification, like how does that work with getting access to the drug thereafter?
Okay. When you've been in a clinical trial and the trial has a positive outcome, generally they can't then deny you access to the drug. And if the FDA approves it for that indication, it's harder for your insurance companies to deny it since it's an FDA approved for that indication. Now, to use it off-label before the approval, your insurance company may or may not agree to do it, especially because this version of phenylbutyrate with the taste mask is new. The Dojolvi is new. There's not generics on the market yet, for them. But generally, in a trial like this, the drug stops at the end of the trial. But if we find out that there was benefit for it, then we can't deny it to patients if their insurance won't pay for it. We have to get creative.
Well, thanks for explaining that, because it is really confusing, like from a patient's perspective, like, okay, so you do this trial and then what if things go well? So it's helpful to kind of understand a little bit about the process, and we deal with insurance companies every day. And so it
Oh,
is,
yeah.
it feels like uncharted territory when there's something new out there. And then how does your insurance affect that? And just for, patients that have never participated in trials, typically it's not an expense that the patient accrues to like participate, like they don't have to pay for the drug while they're in the trial. So if that's part of your question too, know that it's not your responsibility to pay for the medication that you're trying to take in the trial. These are really good questions. Are there any other questions?
I have a question about the continuous glucose monitor one that you mentioned. What exactly is the, like, I know that when they talk about glucose monitoring, they're worried that you're not go in and stuff. The FDA wants them to use continuous glucose monitors. Like, how will that change that?
Well, continuous glucose monitors are much more accurate at high glucose than they are at low glucose. So we don't really have a lot of experience using the continuous glucose monitors on patients with MCADD to see what happens, to see how accurate they are. And we opted not to try to use them in this study since we don't have really a lot of data on how accurate they are. But before we do a phase 3 trial, which is the big placebo-controlled, lots of patients trial, we do plan on trying to get some more data on just having some people with MCADD wear this monitors and see kind of what they look like. Do they seem accurate? Are people with MCADD getting hypoglycemic every night and we just never knew it? Or are they not picking up well in people with MCADD? And so it's just kind of more data to see whether using continuous glucose monitors in the future trials would be helpful. We generally don't follow glucose or continuous glucose clinically in our patients because we find that they just, it just isn't very helpful because we don't want people to be reassured that their vomiting baby is fine because the glucose hasn't dropped yet and everybody go to sleep for the night. So we don't want people to be falsely reassured. On the other hand, when you're, lots of things can make them look abnormal. If there's some orange juice that were left on your fingertips, if they're not as helpful for situations where your glucose is going to be low as they are for like a diabetic where they're going to be high. But if we want to try to use them in a future trial, we kind of want to just see what normal glucose monitoring looks like on people with MCADD.
I think it's super exciting. I recently talked to somebody using that device, and they're diabetic, but they were surprised at times when they were asleep or other times that they wouldn't have considered checking their glucose, that their glucose was lower than what they had anticipated or what they thought, so sometimes it is interesting, kind of like how they discovered that the C7 could potentially be a good fit, what you discover when you're just monitoring things like that.
Serendipity is important in science.
Yeah. Well, this has been an absolutely amazing conversation, Dr. Arnold. We really, really appreciate you taking the time. I'm going to stop the recording now. And if there are a couple more questions, it's about 8 o'clock, so we won't keep Dr. Arnold much longer. But if there are a couple more questions, you can feel free to ask those. I'm going to go ahead and stop the recording.